so good to be here tonight. My presentation may be a little different than you're used to from the college. We're going to talk about navigating the gray. And why are we talking about gray? Well, often the college is seen as setting the rules for the practice of the profession. And that's a fairly black and white world. And what I want to talk to you about is how we're moving into a more gray world. It's not going to be the black and white decisions that we've had in the past. And so the theme of this is, how do we get through that gray area? So we're lots of things as a healthcare profession. We're dispensers, and that's where our roots are. We're counselors, and certainly when I graduated, that's what we really emphasized for new grads. We're advisors, and that's where hospital pharmacy has really changed in the last 25 years, from being in the basement and dispensing drugs only to actually giving options and advice to healthcare professionals who are making decisions right on the wards. And we moved those hospital pharmacists up to the wards. Now we're being asked throughout Canada to move into a role of decision making. And what I want to talk to you about tonight is why that's happening, and can we have a framework or a way of going about doing that? So saying that, I gave a similar sort of talk about this change that's happening in the practice at UBC this spring, and I had the whole faculty of all the students and the faculty there in the meeting. So it was a big auditorium. I bought pizza, so lots of kids showed up, and I really talked to them about the new role and how it's evolving, and how their practice is going to focus as well as decision making. It's going to have the dispensing, but a large portion of what they're going to do is the decision making. I wasn't 100% sure whether they got it or not. So what I want to do is show you how I think they really did. My niece was a third-year pharmacy student, and she was in the audience when I gave the talk. And then later, she gave me a phone call and said, "Uncle Marshall, we won skit night at the faculty's student skit night." And so this is, I'm going to show you what the skit was, and I'm going to show you what it was based on. So first you can see a commercial, and then you're going to see the skit that the students did. So here we go.
Hello, ladies. Look at your man. Now back to me. Now back at your man. Now back to me. Sadly, he isn't me. But if he stopped using lady-scented body wash and switched to Old Spice, he could smell like he's me. Look down. Back up. Where are you? You're on a boat with the man your man could smell it. What's in your hand? Back at me. I have it. It's an oyster with 2 tickets to that thing you love. Look again. The tickets are now diamond. Anything is possible when your man smells like Old Spice and not a lady. I'm on a horse.
Okay, how many people have seen this, right? Old Spice was something that my dad used, and I've never been caught dead wearing Old Spice, but now it's really taken off. So that wasn't the skit, right? That was the commercial. Now let's go over to the skit.
Hello, patients. Look at your pharmacist. Now back to me. Now back at your pharmacist. Now back to me. Sadly, he isn't me. But if he stopped calling the doctor and switched to adapting, he could practice like he's me. Look down. Back up. Where are you? You're in a counseling booth with a pharmacist who adapts. What's in your hand? Back at me. I wrote it. It's a prescription with 2 refills for that drug you love. Look again. The prescription are now Tylenol 3s. Anything is possible when your pharmacist has the pen. I'm on a bike.
So guess what? They won. So really, they got it. They got what I was talking about, moving into decision making. They didn't quite get all the rules just yet. And I know that Anne needs to go talk to them about the rules around narcotics, but that's another story. We are all these things. We're dispensers, and we're counselors, and we're advisors and decision makers. The role that the college will play in all this is we need to ensure as a college that our members, our registrants, provide the public with quality pharmaceutical services and care. And so whether we're involved in the dispensing aspect or in the decision making, that's our role, to be able to set up a framework so you can practice in a safe and effective way. You know what? We've had a lot of change. I've been in the profession for over 30 years, but I actually started when I was 15 years old, stocking shelves in the Langley, Rexall, which is just outside of, about 40 kilometers outside of Vancouver. And my job there was, in that Rexall, there would be like 3 facings of toothpaste, 3 tubes of toothpaste that were there. And when we sold one, I had to go in the back and go to the front and make sure that there's still those 3 facings that were out there. And certainly the way that pharmacy was practiced was different then, but we've seen a tremendous evolution. When I was in Cambridge, I talked to a pharmacist who had a book that listed all the prescriptions that were filled in a pharmacy in Cambridge in 1917. And so as we're flipping through it, we're looking at the types of things that pharmacists were involved in, the things that they were doing. And certainly it was all compounding types of things, although they did fold some powders, and they talked about the ingredients that need to go into that, and there were some suppositories that were made. It's interesting that there wasn't anything that was really curative there. They're all for symptomatic type of relief. And lots of descriptions, and I honestly didn't understand all of the things that were there. But we also looked at what sort of business they were doing at that time. And we looked at the very busiest day that they had in that whole book of all the prescriptions that they filled. And the busiest day was 15 prescriptions. A lot of days were 4 and 6 prescriptions, a half a dozen prescriptions. They did charge big bucks in those days, 34 cents for a prescription, and 75 cents was the biggest that we found. But certainly the practice in 1917 was quite different. Then when we went over to Peterborough, and Chris and I were there, a pharmacist there, it was Mark, actually one of our board members, our council members, showed us a book from the 1920s, and it really hadn't changed that much. But there was more of a standardization, and through the 20s and 30s and 40s, there's reference to the British Pharmacopoeia or the US Pharmacopoeia to really standardize the types of formulations that they had, so you can have that reliable type of result from the products. Because you could have the best formulation, but if it couldn't be duplicated, then you couldn't get reliable results when you prescribe those drugs. And what did we see through the 50s and the 60s? We saw a lot of centralized manufacturing, so that things were pre-manufactured, both tablets and capsules, but also creams and ointments. And we saw that sort of standardization to healthcare, and pharmacists still did some compounding, but a large majority of the things that they were doing were dispensing things that were already manufactured centrally. And I remember when I was in university in the 70s, one of the professors there was talking about dissolution rates of tablets. And it turned out that one of the issues out of the 50s and the 60s was that you couldn't always get the consistency even in the pre-manufactured tablets, and especially in the generics, because if you press the tablet maker made it too hard, then actually it just passed right through and it wouldn't dissolve in the body. And one of the issues with generics in those days was, could you get the same consistency that you could of the brand name? So we had those sorts of issues to deal with. And certainly he came up with a way that you could standardize that sort of thing, and it was a test that Health Canada used. And in the 70s, when I graduated, in mid-70s, late 70s, we were looking at patient profiles, and I was the first pharmacist when I just graduated, first pharmacist in the chain that I was involved in, where we listed all the medications that that patient was getting, and also asked them where they got it filled elsewhere. And we had a paper copy of all those things. And when we filled a prescription, we'd review that paper copy, and that was one of the ways that we did it. Of course, we had manual and electric typewriters, and those are the things that we're dealing with. In the mid-90s, I was on the council of the college in British Columbia, and I eventually became president. The year I was president, we introduced PharmaNet. So how many people are from BC and know what PharmaNet is? Or even know what PharmaNet? Yes. Okay, few people. PharmaNet is all drugs for all people. In other words, every single prescription that was filled on the community side would be listed in the central registry. So when you filled it into your computer, it would send a packet of information off to a central registry with government. And that would give you instant adjudication, and that really paid for itself, because up to that time, you'd wait 3 to 6 months for payment for these things. And by instant adjudication, then you knew that you could get paid on a regular basis every couple of weeks. And so that showed you that it would be paid for right away. But it had a clinical aspect to it too. All the drug interactions and all the drugs that were filled in the last 14 months were listed there. So you could look at that, and it was a really good tool to be able to see whether this was appropriate medication for the patient. And you could make decisions about that patient and whether you need to phone the doctor. You can monitor a little bit better. You could watch for multi-doctoring and multi-pharmacying. And those were really good things. And now, almost right across Canada, except for Ontario, we're using a similar sort of system to that. So Manitoba has a similar to PharmNet. Nova Scotia, Newfoundland, PEI has all drugs for all people in the central registry. So certainly that's a way that the future is going to go. And that was a big evolution in change in the way practice was, and it allowed for a more clinical type of practice. On the hospital side, because I was involved in hospitals, we certainly brought a lot of that information and we integrated the pharmacy system with the lab system so that that system actually would alert you. The lab information would tell you the creatinine clearance, and it would even adjust the dosage of gentamicin or give you suggestions so that you could change that dosage from multiple times a day to once a day if the kidneys weren't clearing the drug properly. And that was a tremendous tool to be able to do. So that electronic tools made a huge difference. And we're moving into a new era as well. We're talking, I know it's a bad word in Ontario, but electronic health records. And we've sort of got stung, I think, in this province, but certainly Infoway is the federal government and the federal arm that's funding it right across Canada. And there is a vision for all drugs and all people right across Canada, but there's a vision for an electronic health record that has medications, and it has immunizations, and it has lab results. And that should be available to all healthcare professionals, including pharmacists, at the right time for the right patient. So that's the vision that we're going to, and how pharmacy is going to evolve into the future. There's another thing that's happening as well, and there's actually an evolution in our population. We're going to have 4 times the number of seniors in just 10 years. That's because there's a generation, the people who are turning 65 this year to the people who are turning 50 this year. That group of 15 years are the baby boomers, and they have a tremendous impact on society. When I was going into school, because I'm one of those baby boomers, when I was going into school, there's such a pressure on the school system in British Columbia that one building was an elementary school in the morning with elementary students going there and elementary teachers and an elementary school name. In the afternoon, that building became a different school name with a different set of students. It would be a junior high and a different set of teachers. In other words, they could not build the buildings fast enough for the population that was coming up of kids going into the schools. What happened about 20 years later? Right across BC, they were closing schools, and it happened in Ontario too. Because traditionally, we've had sort of like a pyramid shape to our population with a small number of people who are 65 and older and a very large number of people who are very young. When I graduated in the mid to late 70s, there was about 5% of the population was over 65. And they're the big users of chronic medications, and they're certainly the big users of all medications. And so what we were dispensing in those days were mostly antibiotics and pain relievers. And that was really the focus, and it's a short-term type of therapy. Now we're looking at people being on the majority of drugs for the rest of their lives. And in Ontario, if you averaged out the number of prescriptions that are dispensed to the population, there's 10 prescriptions for every man, woman, and child alive in Ontario today that are being dispensed. So it's a large numbers of medications. But we know that most of those are going to the people who are 65 years and older. So we are going to have, like when I graduated over 30 years ago, there's 5% of the population that was over 65. Today, it's about 15 to 18% of the population is over 65. In just 10 years' time, 1 out of 4, or 25% of the population in Ontario, in British Columbia, in Quebec, right across Canada, are going to be over 65. Now, other countries have been there with that sort of population demographics. And the USSR, Italy, Greece, actually they got some other issues too, don't they? But those countries are actually in a population decline. So they've had, for whatever policy they had and the demographics, they've had a lot of people who were in the workforce who were paying taxes, and then they moved into a retirement pension type of plan. They're not only no longer taxpayers, but they're actually taking money from the system and paying that sort of thing. Canada is in a good position, but our demographics are just a few years behind that. And we're going to be looking at a similar sort of issue. So why is that important? Well, if you're a politician in Canada, one of the big things that we think of as being Canadian is that we're that a little bit softer, kinder, gentler type of society than our neighbors to the south. And we have this obligation, and part of being Canadian is that we have this universal system to look after everyone as far as healthcare. So we identify being Canadian as having a healthcare system that actually will look after the whole population. But today, even with 18% of the population over 65, you're looking at 49 cents of every dollar that's collected in taxes going towards the healthcare system. And we know that that's going to go up exponentially as the baby boomers come through and become the big users of hospitals, long-term care, and prescription drugs. So it's a really big issue for the future planning of healthcare in Canada. What are the governments looking for? They're looking for, the two issues are sustainability of the healthcare system because it costs so much, and also accessibility, because what are we hearing today? You can't get a family physician even in the Toronto area. It's getting difficult to get a family physician. And when I go throughout Ontario into the smaller towns, I can tell you that that is a huge issue. And if your whole healthcare system is dependent on going through a family physician to be able to have access to the different parts of the healthcare system, whether it's referral to specialists or getting physiotherapy or getting prescription drugs, and all of a sudden in Ontario, 10% of your population, or 1.3 million people, can't get a family physician, then all of a sudden your universality to your healthcare system isn't there anymore. I was at a meeting, a national meeting in Vancouver about 10 days ago, and the registrar from Quebec was talking about the issue of access to the family physician in Quebec. A full 30% of residents in Quebec cannot get a family physician. And so actually there's a big push a couple of years ago, just a few years ago, that looked like there wasn't going to be a big scope change for pharmacists. But now they're looking at huge scope changes for pharmacists in Quebec because, you know, if your only way to get into the healthcare system is physicians and there's not enough of them, then you look at other healthcare providers who have a good and solid education to be able to help with that system, to add some capacity to it. And it's no coincidence that nurses and optometrists in British Columbia, naturopathic physicians and pharmacists have the ability to prescribe now. And I think there's over 23 different professions that have that ability to do some sort of prescribing in their area of expertise. And that makes some sense if you want to be able to add some capacity to the healthcare system, because today we're having this kind of problem. What happens when there's 4 times the number of people who are over 65, the big users of the healthcare system? It's going to be a real issue, and governments need a solution for that. The solution needs to be around sustainability, and we need to be around accessibility. And guess who is the most accessible of the healthcare professions? It's the pharmacists. Guess who have a lot of knowledge and skills about medication? It's the pharmacist. Another issue that's happening in the healthcare system, which is a fantastic health system that's there. You know, we can do some amazing things, and I know of personal friends who've had grandchildren who are born, and they're really tiny babies, they're premature, and yet those babies will have an excellent chance at living a healthy life because of the technology that's there. And 20 years ago, they wouldn't have had that sort of chance, but today they do. And there's lots of examples that you can think of how the healthcare system really makes a huge difference. But the healthcare system causes harm as well. People get infections when they go into hospital. They're hospital-acquired types of infections, and they're extremely serious, and they can be life-threatening. People fall in long-term care facilities and daycares and hospitals, and those injuries sometimes are life-threatening because they're at-risk types of patients. But 80% of the things that go wrong in the healthcare system in institutional care is around medications. So I was part of a conference, and we were talking about the things that go wrong in the healthcare system, And it was mostly to hospital pharmacists, and we're mostly talking about the medication systems and where things can go wrong. And it's not just that they got the wrong drug, although it happens once in a while, and it's not just that the drugs are missed, but there's adverse reactions, and we know that the medications, the therapeutic index, the safety margin that they have are so very narrow, and we're pushing those drugs to the limit in people who are compromised, and things do go wrong with them. And part of that panel, a member of that panel was saying that if the healthcare system was a disease, it would be the 6th leading cause of death in North America. Think of that, that would be like an epidemic happening. The other panel member was arguing that that person was wrong. If the healthcare system was a disease, it would be the 4th leading cause of death in North America. And I was thinking, I said it out loud, does it really matter? If the healthcare system is causing that sort of harm to patients, then society won't be standing for that for very long. We're going to have to find a way to be able to deal with that huge issue. What we're going to have to do is find a way that we have the medication experts. And I think pharmacists can play a huge role in being the medication experts to make sure that the medications are safe and effective and appropriate for the patients. You know, there's other healthcare professionals out there. We often think of the physicians as the medication experts as a society. I have a daughter-in-law who is a physician. She's in her very last year, only a few months left before she's finished her family residency. She was working in the Bella Coola Valley, which is on the coast of British Columbia, and it's a very small community of about 5,000 people. A couple towns in there, but in late August, early September, they had some flooding that happened through there. And nobody died, but a lot of people were injured during that. And she was the physician in that hospital looking after that population. She got a tremendous experience. It built her confidence to be able to handle a situation which was really a natural disaster and an emergency. They were able to fly in by helicopter, additional physicians, but it took more than a day for them to be able to get into that area because it was so sopped in. And so it's a great experience for her. And the training that she got at a UBC at the University of Northern British Columbia was just fantastic. The experience that doctors get today to be able to diagnose, come up with the treatments, come up with plans, and to be able to make decisions and deal with emergency situations is just amazing. So I'm quite proud of what she's accomplished. But we've talked over dinner about what she learns about medication. And her formal training is very, very little. Almost everything that she learns is through preceptorship, and when she's working with other physicians, whatever they're doing, she sort of learns that, okay, I can do it that sort of way. But it isn't the systematic type of learning that we've learned. And certainly there's not the depth to the learning about medications. There's a depth of learning about a broad number of things, but not about medications that we have. Nurses will put themselves forward as a patient advocate. And they will make sure that their patients are looked after in the very best way possible. And those nurses are putting themselves forward as medication experts in many cases. And you know what? They do know something about medications, but their training around medications is probably less than what the physicians have. And so they want to look after their patients in the best way possible, but we already have a shortage of nurses, and we need them to be able to develop the care plans because they're actually moving into the decision making around patient treatments and care plans and follow through and those sorts of things. I think the person who's best, the profession that's best positioned to be able to do this is going to be the pharmacists. So if we're going to move into this role as medication experts to be able to help that aging population and try to make our healthcare system as safe as it can be, then we're going to have to move into this role of decision maker. So we have been used to being very accurate, and that's what that dispensing is where we've been focused on up to now. And we've been focused on giving advice and giving options to other people who are making decisions. But now we need the capacity for pharmacists to be able to make decisions about therapeutic outcomes to do with medications, to give advice around that. So the question that each one of us need to ask ourselves is, do we have that knowledge and skills and ability to be able to do that? when we're faced with a situation, just like my daughter-in-law who's a physician, she's looking at, okay, I'm presented with a situation. I have to make a decision. Do I have enough knowledge about the situation? Do I have the skills to be able to deal with it? And do I have the ability to do that? And then she'll make the decision either to move forward with treating that patient or referring them on to someone else. And we need to be able to move as a healthcare professional into that sort of mode as well. So if we're making decisions, we're really talking about moving into a gray area. You know, dispensing can be fairly black and white, and you can have a lot of rules, and you can follow the rules to be able to dispense the prescription, and it's generally going to be safe in that regard. It's just going to be the right medication. But when you're making decisions, there's not an absolute right answer. You know, it's based on your assessment and based on the best information that you have at that time. So it's no longer black and white. You're really into a gray area. And when we're doing that, we can't be like cowboys shooting it up out there. We have to have some sort of method to the way we go about doing things. And really what we need to do is ensure that we're all doing the right thing for the right reasons. So we need to find a way to do that. Step one in the method to be able to do that is to begin with an end in mind. So what's the end point? The end point isn't making sure that you've absolutely followed every single rule. The end point is to protect and promote the health and well-being of your patients. So really that's what we're trying to achieve when we dispense medications, when we give advice about medications, when we're making decisions about medications. We have to put that end point of where the best place for the patient first. So if we're going to do that, we have to figure out a way to get there. And I'm going to give you a method to get there. It's around clinical judgment or decision-making, professional judgment. It's called lots of different things. It's founded in pharmaceutical care. It's the foundation piece for Alberta's pharmacist prescribing and in British Columbia adapting prescriptions. And it's really found in our standards of practice, which are national standards of practice. They're the model NAPRA standards of practice, our national organization. We need to go through a thought process. So as a pharmacist, we have to ask ourselves, when we're faced with a situation, do I have enough knowledge about the condition and the drug? Pretty simple, but you need to decide whether that's a situation that you can sort of deal with. And do you have enough information about the patient and their health status? So those are two things. In hospitals, we had a fair amount of information about the patient and their health status because, well, you could tell how many bowel movements they had in the last week. There's a tremendous amount of information on the charts. On the community side, though, we've learned how we can do assessments and ask patients questions to be able to make a real difference and understand the patient and their health status. Do you have a valid prescription? Because you need to have some sort of plan as to where you're going with your medication, your decision making, and the prescription is part of a plan. It's the therapy that's been prescribed. And so in many ways, you need to have that prescription to be able to move forward. You have to decide what's in the best interest of the patient because, like every healthcare professionals, we don't make our decisions in our own best interest. Healthcare professionals make their decisions in the best interest of the patient. And you could argue, well, gee, you can dispense, but should you be making decisions if you dispense because you might have a financial gain? Well, you need to demonstrate that you're making those decisions in the patient's best interest. Physicians have the same dilemma. Physiotherapists have the same dilemma. All dentists have the same dilemma. It's not unique to pharmacists. But the way you deal with that is make sure that those decisions are in the patient's best interest. And then there needs to be some sort of consent that's there. You need to document or write down the reasons why you're making your decision. And then because the patient's part of a team, you need to notify them appropriately. So whatever you're dealing with, you need to be able to notify the appropriate physician, nurse practitioner, that these are the reasons that you did what you did. So what I want to do is give you a practice scenario. Maybe some of you can relate to this. There's a patient, they're discharged from hospital, they go to their community pharmacy, there's a whole list of medications that they're on, but you know what? The anticonvulsant medication isn't there on the list. How many people have been faced with this sort of dilemma? Almost everybody. Okay, so you can probably relate to this. Some more information. This is your patient. This patient's been coming to you for years. They've been stable for years on the anticonvulsant medication, so This is something that they've had for a long, long time. The patients went to the hospital, but that hospital stay was not related to convulsions or the medication or anything like that. The patient knows of no reason why it was discontinued. The patient feels that they should be continuing on this and are asking for that medication. And guess what? You can't get the prescriber. And you know what? Even if you could get the prescriber, likely that prescriber wasn't the primary care person in the hospital. And likely they were either the emergency physician or a hospitalist that hardly knows this patient at all. You probably know this patient better than they do. It's not the family physician, because in most urban hospitals, you're not having the family physician admitting into the hospitals. So this is the situation you dealt with. Your problem is you don't have a prescription for the anticonvulsant medication. So what are you going to do? Okay, so remember what the objective is. Step one is to begin with the end in mind. What is the best thing to do for your patient to ensure that their best health outcome is achieved? Okay, so that's where we need to go. That's where we need to go in this situation. So let's work through the process. Do I have enough information about the condition and the drug? You know, for most pharmacists, this is pretty general, and you know enough about this condition. The drugs are very, very common. So this is something that most pharmacists would say yes, and they could be able to handle. Maybe an oncology pharmacist who's in a very specialized practice would say, no, I have to refer to someone else, but most pharmacists could deal with this. Do you have enough information about the patient and their health status? Well, it's not that you got the hospital record, but you know a tremendous amount of information about this patient. They've been going to you for years. You actually know, because they're right there, that they were discharged from hospital. They just told you that. You can look at them and see that they're much better, that they're in a good condition right now, so they're quite well off health-wise, so they're in a good position. So you can gather a fair amount of information about this patient. So yes, you do. Do I have a valid prescription? Well, you have a good idea of what the treatment plan is. It's not to have convulsions, right? But you don't really have the valid prescription, so you have to say no to that. What's in the best interest of the patient? Probably continuity of care, so you want to be able to continue that. The best interest of the patient is not to have the convulsion, right? Does the patient agree? The patient is asking for the medication, so that's a clear indication that there's agreement. So you need to make a decision, write down the reasons why you're doing this, okay? Write down your rationale, and then notify appropriately. And probably not trying to track down that physician that wrote the order, because who needs to know about this the most? It's probably their family physician. And in British Columbia, where there is adapting of prescriptions, we found that when we notified the family physician, sometimes that was the first time they actually even knew that that patient ended up in hospital. And so in many ways, they were very grateful that they could find that out and they could do a follow-up with that patient to make sure that they're doing okay. They made a phone call and did a follow-up visit with them. Okay, so this is a real practice scenario. You know what it's all about. What happened? This is a real case. I learned about it through a coroner's report in British Columbia when I was registrar. You could read between the lines of the coroner's report that they were amazed that the pharmacist didn't feel that this was their patient and they had some sort of obligation as their patient to be able to have the continuity of care to be looked after. And that patient didn't die that evening, but it was later, just a few days later, that they had a convulsion and they passed away. The coroner also asked me, as registrar, if I could talk to pharmacists in British Columbia through a newsletter or something, some sort of communication, to talk about our obligation as a healthcare professional to our patients, to be able to make sure that there was continuity of care and that we do have an obligation when the patients don't have any other choice to be able to help those patients through and be able to bridge that. And they had looked at our website and they saw that in British Columbia, pharmacists had the ability to give refills, full refills, for the length that that prescription was still valid. You could give the full amount of whatever it is for multiple times as long as you did an assessment. And actually you got paid for doing that too. Or you could give an emergency supply, enough to be able to get that person over a week until they could see a physician. or doing those sorts of things. So what I did is I went to visit that pharmacy and that pharmacist to learn a little bit more because I had to understand what I needed to communicate. And when I was talking to that pharmacist, they really didn't think that this was their problem. They really felt that it should have been the physician that was either writing the order or the patient should have gone to find a physician. And then when I talked a little bit more about that, and I questioned that pharmacist, all of a sudden his jaw dropped and he realized that his decision, that was a decision not to give the medication. It's a decision to give it, but it's also a decision not to. And that decision not to actually resulted in somebody dying, and that person had to live with that decision for the rest of their lives. So it is a serious situation, and that person really had remorse because of that decision that they made. When I talked to the manager of the pharmacy, that manager got it right away. And actually they looked at their processes and they looked at ways they could do an orientation for their new pharmacist coming on, because this is a staff member that hadn't been there a long time and a fairly new grad. So they looked at those sorts of processes and they were looking for ways that they could actually make sure that people understood the options they have as pharmacists when a patient presents themselves like this. So there's lots of barriers along the way for us to practice in this way of making decisions. There's some people issues, and you know what? In 2010 in January, there's an article in the Canadian Pharmacy Journal, and it talked about our pharmacists, their own biggest barrier to be able to move forward in new practice. And that's not that hard to understand, because any group of people, if we've had a way that we practice for a long time and we're looking at changing, but the way that it was very successful, and there's so much pressure to continue to do large volumes, and it's really hard to make some of these switches. And how many people have read the book, Who's Moved My Cheese? Okay, several of you. And for those that didn't, I'll give you the really condensed version. There's a group, it's mice, but that's okay, a group that goes through a maze and they find a cave full of cheese and they keep going back and they're satisfied because they can eat the cheese there, and so they got the reward. But after a while, the cheese was all eaten and there was no more left in the cave. A group kept on going back there and they were still hungry, right? Then another group sort of found another way through the maze and found even a bigger cave, and there's some cheese there, really Reader's Digest version, and they were able to be satisfied. So anyways, we need to look at ways that we can really find a way that we can make a difference and find a new way for reward. You know, prescribers are a barrier, and when we introduced adapting prescriptions over 3 years ago in British Columbia, there was a group of people who thought this was the greatest thing, and they were often in small communities, and they had so much pressure to look after the population in those communities, and they were really working long hours. And so when they learned that pharmacists could actually do the refills and do an assessment, and if it wasn't appropriate, that pharmacist would send them to the physician, but if it was all in line and appropriate with the proper monitoring that we've learned in pharmaceutical care, that patient would get their refill and they wouldn't have to take the time of the physician. And so in those cases, the physicians were telling the patients, please go to your pharmacist for those refills. Now there was a few cases, and actually only 3 or 4 in a very short period of time when this was first introduced, that some of the physicians actually put signs up in their physicians' offices saying that if you get your prescriptions renewed at your pharmacy, we'll drop you as a patient. And when the College of Physicians and Surgeons heard about that, that stopped right away. And sure, there was probably 20% who were in favor and 20% who were opposed. And you know what? 60% in the middle were just watching which way I was going to go. And after 3 years, I can tell you there was not one complaint to the College of Pharmacists about pharmacists adapting prescriptions during all that 3 years that I was there. There wasn't one complaint to the College of Physicians and Surgeons. They found a way to be able to deal with it, and life went on, and actually hundreds of thousands of British Columbians got the advantage of accessibility and got their prescriptions refilled, doses changed, directions changed, and even therapeutic substitution, because those are the things that pharmacists had the ability to be able to do, and they made a real difference for people's healthcare. We actually did some research projects on it. What about patients? You know what? Every single survey in the last 10 years have put pharmacists either at the top or in the top 2 of the most respected healthcare professions. Fantastic reputation, except that a study out of Alberta showed that they don't expect very much from us. As a matter of fact, people seem to be more patient waiting in line for a Starbucks coffee for 15 minutes than they do waiting for a prescription for 15 minutes. So we actually have a little bit of work to do on the expectations that the public has of us. So you know what? Politicians are just a reflection of what the public is. And when I took the job on in British Columbia as registrar, one of the first things I did is I went and met with some politicians. I knew some from my healthcare days. And I met with them and we talked about what a difference that pharmacists could make in the healthcare system to add capacity, add accessibility to the system. And when I told them the things that pharmacists could do and are doing, and this is within the scope, they looked at me and you could tell they had not experienced what I was talking about. So I went back about 6 months later, and there was several of them that I talked to over that next few months, and they said, you know, Marshall, I heard what you said. I went back to my pharmacy, and when I started asking about these things, my pharmacist was doing it. They started doing those sorts of things. I had to ask, but all of a sudden I was getting that level of service. And they did it gladly, and they seemed quite pleased to be able to do that. But the pharmacist hadn't stepped out to be able to make that happen without that sort of initial reaction. A couple of them said, you know, I went back to my pharmacy and I didn't get that sort of service, but I switched to another pharmacy and I did. And you know what? I do think that they could make a difference. So actually, when we think of what the public expects, we have to sort of raise the expectations of what pharmacists can do, inform them, help educate them as to, you know, we can make a real difference, and these are some of the ways that we're trained to be able to do that. You know, in the example I gave, there were some workflow issues. That pharmacy was really geared to be able to get a large number of prescriptions through very, very quickly. They had a counseling room, but it was full of boxes. And actually, right after I talked to them, the manager made sure that that was a counseling room for after that. And they took it very seriously, and they actually changed a lot of the way they had their processes, and they did set up ways that it was easier for the patient counseling to take place. You know, there's a time in technology, and certainly there is technology to be able to help us, but it doesn't seem to be coming fast enough with the aging of the population. And you're seeing pharmacists filling 200 and 250 prescriptions in a shift. And you're only talking about a couple minutes that you have for every single prescription if you want to do that. Never mind the time of phoning the physician and going and talking about OTCs and looking after the Schedule II stuff and all those things. It's a huge issue around, do we have the time to be able to do that? I'll talk a little bit more about time a little bit later. So those are all issues. But another issue is the payment for all this. Is there a value proposition, not only from the receivers and the payers of this, but is there a value proposition for the healthcare professionals who are actually providing the service? And there has to be that balance there. As a college, I can tell you that it needs to be there. As a college, we can't engage in the negotiations for what that will be, but we can make statements to say, if you want, as a society, pharmacists to practice in a new way, that has to be a fair compensation for that new way of practicing. You know, we're doing a bit here in Ontario. We are making links with other healthcare professions. We're making links with government. And this afternoon I was meeting with the Ministry of Health with a couple people there. And we're meeting with the association, and we need to do this at a provincial level together. But I'm also emphasizing that at the local level, you need to get to know the healthcare professionals in your community and be able to develop a network to be able to really make a difference, to overcome some of these barriers. So one of those barriers has to do with confidence. I can remember the day, I've got two sons, Michael and David, and I can remember the day for each of them and how sunny it was and everything. It's ingrained in my memory that they said to me, Dad, I'd like to take the training wheels off my bike and I want to try to ride my two-wheeler. And so what we did in each case is there's a new subdivision just above where the house was, and there's a newly paved cul-de-sac. And so we went up there, and I did exactly this. I walked, and then I sort of trotted behind the bike, holding onto the back of the seat. And then with Michael, he says, okay, I'm ready. And I let go of the seat. He wobbled a fair amount. And then, in about 4 or 5 minutes, he was able to keep it all under control. And within 15 minutes, he could ride all over that, around that newly paved cul-de-sac. With David, he actually fell the first time, but he got up. He wanted to go at it again. And the second time, he was able to, with less wobble than Michael, be able to take off. And then within a few minutes, within 15 minutes, they could ride that bike anywhere. It was just amazing to be able to see. Not only that, but when they were in their late teens, early 20s, they were competing in Canada Cup mountain bike races. They didn't win any races, but they were ranked nationally in their competitions. They moved from a time when, I was so pleased that they were able to ride their bike by just letting go, to them developing a level of skills, knowledge, and ability that far exceeded anything I expected at that time, at that moment when I let go of the seat. You know what? We need to get the confidence, and confidence is learned through practice. In other words, if they had never said, okay, I want to be able to ride that bike and say, okay, Dad, let go, then they would have never been able to experience those things and the competition and those levels of satisfaction to be able to perform at that sort of level. Another thing that we have to do is have collaboration. So each one of us work in a community, whether that's a community that's a small town or whether it's a community as a suburb of a large urban center. And you know what? You probably can identify no matter what practice you are, 15, 18 physicians who are 80% of your volume. One of the things we need to do is get to know those people. If you realize that a family physician does not refer just to any specialist, they only refer to the specialist that they know and they trust, because they want the best health outcomes for their patients. So they're going to refer in patterns that they know that patient is going to get the very best that they can possibly get. So at one time in my career, I was a hospital administrator, actually a healthcare administrator, because there's multiple communities and multiple hospitals in those areas. But one of the things that we had is we had one orthopedic surgeon, and that orthopedic surgeon had a wait list of almost 3 years for people to get in and get their procedures done. And what we did is, after a long recruiting campaign, we were able to recruit another orthopedic surgeon. But I was so surprised, because after even a couple months, we couldn't even fill the slate of the new person. There wasn't enough business for that person to be able to do that. And we were wondering why, because the other person had like a 3-year wait list. And then we realized that the physicians were referring in the patterns that they knew to the people that they knew, and they didn't know this new person. So what we did is we had a big wine and cheese party, and we had both specialists there, and we made sure that they're seen talking to each other, and the experienced person was introducing the new guy to all the people. And it took about a month or two, but we had the slate filled with that person, and probably within a year, they had equal amounts of wait lists, and it's far less than people waited half the time or a quarter of the time that they waited before, because there's more capacity into the system. But the point is, they had to get to know that person before they trusted to be able to send their patients that way. And if we want to be able to develop those relationships with physicians and other prescribers in our community, we have to find a way to be able to get to know those people. Relationships are built one contact at a time, and every time we connect with one of the physicians, we need to make sure that that's a positive experience and they get to know us just a little bit better. Or a nurse practitioner, or one of the other 20 different prescribers that are out there. So the role of the college in all this is really twofold. We have to deal with the product preparation and the clinical services, and we talked a fair amount about the clinical services. But one of the issues that we're facing is time. And over the years, when I first graduated, I didn't work with a pharmacy technician, but we didn't do that many prescriptions if I look back. I thought we were busy, but 75 was a really, really busy day. 25 to 50 probably would be an average day. And those sorts of things, we did the product preparation and we did the clinical services. And I got trained under pharmaceutical care, and I think I did a fair amount of that when I was in practice, both in the community and hospital side. Okay, but over the years, when the volumes got up as the patients started aging, as the population ages, we got larger volumes. And what do? We took people who were not regulated and assigned them tasks to be able to do things in the pharmacy. A full 50% of those people who were, we called them pharmacy technicians or sometimes pharmacy assistants in those days, had no formal training at all on the community side. Our surveys show that half of them had no training at all. They just had the in-house type of training. A full 10% in hospitals had no formal training. So that was one of the issues, is you could delegate a task, but you can't delegate the responsibility or the accountability or the liability. That still remained with the pharmacist. But this model has worked very well, and we're able to do a lot of prescriptions in a very safe way. But one of the issues is as things get more complex, we need to be assured as a college and as a society that there's a level of skills, knowledge, and ability for people who are involved in these things. And there's a fence around the things that they can do, which we call the scope of practice. So as colleges, to ensure that both functions are safe and effective, colleges right across Canada have said, this is going to be the level of education for a regulated pharmacy technician, and this is the fence around what they can do. This is the scope of practice. These are the things that they can do. And so those are now identified, and that's right across Canada. So what does it mean? It means that you know that a pharmacist has achieved a certain level of education. They come through accredited programs at different universities, and they've written a PEBC exam. Then a college will accept them into the profession as a registrant. And then we look at, they need to abide by the legislation, the standards of practice, the code of ethics, and they're committed to lifelong learning. And now we have a regulated technician who has achieved a certain level of education and written the PEBC exams, and we accept them as a registrant, and they have to abide by the legislation of the day, the scope of practice, and the code of ethics, and they have a commitment to lifelong learning as well. Now that's not unique amongst healthcare professionals. As a matter of fact, if you look at the teeth people, dental assistants and dental technologists and denturists are all regulated healthcare professionals, and they've been for many, many years. And yet if they make a mistake, people are uncomfortable, but very few people die. If a pharmacy technician makes a mistake, the consequence of that can be life-threatening, and people can die. So in many ways, if you talk to the general population, they would be amazed that actually there isn't a standard for education up to now, and there hasn't been a fence around the things that they could do. So regulated pharmacy technicians are there to be able to do that sort of thing. Okay, so it's here in Ontario, it's here in British Columbia, it's here in Alberta, and soon to be here in Saskatchewan and Nova Scotia, probably within the next year. So how do we integrate that into the workforce? Okay, so you know that your standards of practice means that a pharmacist must continue to be involved in every new and refilled prescription. The standards of practice say maybe you're doing a little bit less because it's not a brand new prescription, but you have to monitor that it's still appropriate for that person to have that refill prescription. The pharmacist is responsible for the assessing of the appropriateness of the prescription and resolving any drug-related problems that develop. And the regulated technician is responsible for the technical aspects of preparing that product and the things around that, the final check of making sure that that's what's in the container. So I want to give you an example. I won't use a bottle of water, I use my coffee cup, okay? So a pharmacy technician can ensure that in this 500 ml container of a coffee cup, there is about 250 mils of caffeinated coffee with about 30 mils of 2% milk. And they can assure me, and their license is on the line, that the contents of this container are what they signed off on. So they can be responsible for that. So they can look after that part of it, the product preparation of it, and what the container and what it's labeled as. But only the pharmacist can tell me whether it's appropriate at 8 o'clock at night that I be drinking caffeinated coffee or whatever the issue is. The pharmacist has to determine that that's appropriate for me to be able to take. And you do that by patient consultation. So how can it work? Well, you know, all along we've been able to have one pharmacist do the product preparation, the dispensing side of things, and also the clinical services. And for the last 20, 25 years, 30 years, we've had pharmacists working with unregulated people, and that can continue into the future. So both models can work in a pharmacy or in a shift or even for part of a shift. You can do those sorts of things. You also can have a pharmacist with a regulated tech, and the regulated tech can assure me that the contents of this is water and not milk, and there's, 350 mils of water in this 500 ml container. And the pharmacist needs to make sure that that's appropriate. Or you could have a pharmacist and a regulated technician working with unregulated people. And we're seeing that in British Columbia already, where there's regulated technicians in some of the hospital settings. The regulated people need to check what the unregulated people are doing, but you see a mixture of all those. By the end of the year, there will probably be about 500 regulated technicians. Right now, we just turned the 400 mark this last week. Sounds like a lot, but it's going to be a slow and gradual process because remember that there's 4,000 pharmacies in Ontario. Okay, so it's going to be a while before there's even enough to have one in every pharmacy. It's going to take quite a while to be able to do. There's 13,000 pharmacists in Ontario. Okay, so we've got a lot of pharmacists, and it's going to take some time before you get into large numbers of pharmacy technicians. Today, there's 26,000 people who are working in pharmacies who are not regulated. For every pharmacist, there's 2 people behind the counter who are unregulated. We called them technicians, now we're calling them assistants. So we've already developed a model where unregulated people or people who are non-pharmacists are working behind the counter and making things work. We can integrate a regulated technician into that model, but it's going to take some time, and it's going to take a while, and it's good that it's going to take some time because that way we can assure that it's going to be safe and effective, and pharmacists can focus with time, the time that's being freed up of doing the checking, to really make a difference in decision making for patient care. There's a bunch of things that are happening in scope of practice, and actually you know more about the refill authority than I do. I know about the British Columbia one, but back in March, you've had the ability to do refills, and certainly that's going, and that's part of the scope of practice. We had a current focus, and I was in discussions with Anne and Connie and Della around expanded scope of practice for pharmacists. That was just today. But the regulations are with government right now for approval, so those things can move forward, and we can move on that. You know, what are the future things that we can do? Okay, so one of the things we can do is immunizations and routine injections, and certainly that's been talked about for some time here. You know, British Columbia has it, Alberta has it, Nova Scotia, New Brunswick, actually lots of provinces. In Ontario, we're looking at doing that, and I think it was about 3 or 4 days into my job, we had our first council meeting, and that council directed me as a registrar to start the consultation process to move forward with immunization and routine injections. And when I first heard about it in British Columbia, because in British Columbia we had this authority, but we didn't ask for it as a profession. Actually, the government came to us, and right then, it was like 2 years ago, and the H1N1 was about to hit. This is the springtime, and there was stories about 1 out of 4 or 1 out of 3 British Columbians were actually going to be incapacitated, not being able to go to work because they would be hit. So can you hear me now again? New battery. Okay. So immunizations. We were able to put this together in just a few months. At that time, I was a little bit skeptical because I thought immunizations, okay, that's good, except it's sort of like it's a technical skill. It's not really a clinical skill. And why would it be important for pharmacists to be able to do? And then I realized after a few pharmacists were doing it, and they started to tell me some stories, I realized how important it is. So I'm going to go up to Rose here. Rose, if I had a piece of cold steel in my hand and I was going to shove it into your arm, it'd take a tremendous amount of trust on your part for me to be able to do that, right? You know, people don't want things shoved into their bodies unless there's a really good reason and there's a trust that's built up. And we found out that pharmacists who are able to do the immunizations develop this level of trust with their patients that we realized that physicians had developed and nurses had developed with their patients. And then when the pharmacists talked to those patients about other aspects of their pharmacy care and pharmacy management, that they were listened to in a more acute way. They were listened to better than they ever did before, and they followed the instructions because they built that level of trust up with their patients. And so there's a tremendous amount of trust that goes with it, and we found that pharmacists who actually gave immunizations, sometimes the patients would wait for that pharmacist to come on shift and then want that prescription filled by them. So it developed a lot of customer loyalty. And now, after 2 years going into the third year of immunization in British Columbia, there's over 60% of the community pharmacists who have the skill to be able to do the immunization, and it's made a real difference. And public health loves it. And by the way, the percentage of population that's immunized is way higher than it is in Ontario. I think we have here the lowest in Canada. It's around 30% that is immunized. So there needs to be some way that we can actually build enough immunization in a population to be able to protect us. Because at 30%, that's probably not a level that's actually going to work very well for a population. What about advanced practitioners? That means different things to different people. So I want to just do a little example to explain what it is. I'm going to pick on Don, right? So Don's a really healthy individual. He works out all the time. He runs 3 miles every day. But you know, lately he's been feeling a little bit tired. And lately he's saying, oh, you know, I'm feeling this real heaviness in my chest. So he goes to his family physician because he's one of the 9 out of 10 people in Ontario who actually has a family physician. So he goes to his family physician. The family physician looks at Don and says, you know, I don't like this. And he listens to his heart. I'm going to have to send you to a cardiologist. And he goes to the specialist, the cardiologist, and the cardiologist does all these tests, stress tests and maybe and injects it with radioactive stuff and everything. And he finds out that he's got some narrowing in the coronary arteries. And he refers him to a very specialized type of surgeon at a cath lab. And this person does angioplasty. And what he does is put a catheter into his heart and puts a stent there. And all of a sudden, Don's feeling better because those arteries are opened up. But the healthcare system doesn't drop him right there. Actually, they refer Don to a healthy heart program. Most hospitals who have a cath lab have a healthy heart program of some sort. Maybe it's called something different. But there's a team of people who will look after Don. And there's a physician, and there's a dietitian, and there's a physiotherapist, and there's a pharmacist as part of that team. And when Don goes to the dietitian, the physician doesn't tell the dietitian what to tell Don about his food. Actually, the dietitian does an assessment of Don, finds out what he likes and what he doesn't like, and has a good idea of what would be good nutritional value, and then makes recommendations based on that. It comes up with a meal plan so that Don can live the healthiest life possible for the rest of his life. And when he goes to the physiotherapist or physical therapist, whichever you have on that team, the physician doesn't tell that physiotherapist what exercises Don should be on. That physiotherapist does an assessment of Don, and based on what he likes to do and based on what would be good to live the best life possible in an active way, they make some recommendations and come up with a plan and a way that you can monitor that you're actually achieving those things. When it comes to the pharmacist who has the most skills and training, longest period of training of any of the healthcare professionals, the physician tells the pharmacist what medications that patient's going to be on. And then the pharmacist can tell them how best to take those medications and what to watch out for. But why couldn't that pharmacist, if they had the skills, knowledge, and ability and could demonstrate that, why couldn't they initiate that therapy? Those other healthcare professionals are doing that. And in Alberta, there's about 130 pharmacists who have that level of training. They're advanced practitioners. They have demonstrated that they can come up with plans, pharmaceutical care plans for their patients, and they're working in healthy heart programs, diabetes clinics, HIV clinics. Often they're community pharmacists. More than half the time the baccalaureate trained, they're not PharmDs, but they have demonstrated that they have that level of skills, knowledge, and ability to be able to do that. And they have a very satisfying and rewarding type of practice. And so even in, I'll use the initials of the chain, it's London Drugs, there's one fellow, Rick Seaman, I went to a presentation that he did, and he was saying how satisfying it was because he's got the special authority and he works in diabetes clinics, and it's made a real difference in his practice. Is that where you want to go as a healthcare profession, be involved in those sorts of things? What about prescribing for minor ailments and using prescription drugs? I want to tell you about the last time I went to a walk-in clinic. So lots of walk-in clinics around here? Yeah. Okay. So you sort of know the routine. I was there, waited 2 hours in the wait room, okay, in the waiting room, and then I went into this little cubicle, and I waited another 15, 20 minutes there. And then a physician comes in, and he looks at me and he says 2 words, "What's wrong?" And I said, "I think I have pink eye." And he looked and he says, "Yup." So 3 words. Wrote a prescription for garamycin, and I was out of there. And I was thinking, why couldn't I have gone to my pharmacist who actually knows me better, and I've got a relationship with that person, and it's a self-limiting condition. I probably could be treated for that, and if it doesn't work, then I can be referred on to a physician for those sorts of things. But 98 or 99% of the time, I know that it's going to work. So why not be able to go to a healthcare professional who is very accessible, who can make a real difference? Nova Scotia is prescribing for minor ailments. Certainly the United Kingdom, Australia, other countries are. Is that the type of thing that you see that you'd like to be involved in your practice? So we're going through ongoing collaboration around this, and we're looking to see, is this the way we need to go? We're already moving on the injections, and we're looking at those others. What about remuneration? What about payment for this? How many people have seen Jerry Maguire? That's Tom Cruise, and yeah, you've seen it. Okay, this, if you haven't seen it, it's really this agent who's got one client, a star athlete, but the star athlete won't perform unless he's shown the money. And so this is a yelling back and forth over the phone, show me the money, show me the money. And that's one philosophy we could have. Okay, how many people have seen Kevin Costner in Field of Dreams, right? Okay, and so a different sort of philosophy. Poor Iowa farmer, this is his livelihood, his field, his cornfield, yet he turns it into a ball diamond, and you know what? They come. And a different sort of story, build it and they'll come. You know, the choice is ours, and we have to decide when we want to jump in, okay? And whether it's all going to be laid out for us or whether we have to do a lot of things and hope that it's going to happen. But likely it's going to come somewhere in the middle. And actually it's already happening because there's a lot of payment for different clinical services right now. So those things are happening right now. And is it enough? Is it fair? Is it the value proposition on both sides? We have to get involved and experience it before we're going to really know. And we can adjust it as we're going to go. But if we don't let go of the seat of the bike and just get out there and experience this, we're never going to know whether it's actually going to work or not. So the choice is ours. And certainly the associations in this province and across Canada are involved in the negotiations on what that's going to be. But we do have to get out there and experience it. It's important that colleges say that it's important that it is recognized and rewarded. And after that, it's the associations that will be involved in what that is actually going to look like. And it has to be a value proposition for both those who are providing the service and those who are receiving it. So there's rules out there. And I started talking about rules, and you know what? Della, who's the deputy here in Ontario, gave me some statistics because I was looking for something to sort of relate this to. And I found out that there's 11 million vehicles in Ontario. Okay, and we have driver programs. People are well trained to be able to drive, and so we have quite a rigorous system for us to be able to get there. 11 million vehicles. And then I found out that there's 9 million drivers. So there's 11.2 million vehicles, only 9 million drivers. So I was doing the math, and it's like 2.2 million vehicles are out there without drivers. But then I think coming here on the 401, they were all on that road. Anyways, it wasn't moving very much. It's amazing, though, that you can have that many drivers and vehicles on a limited number of roads, and you can go home tonight and you can feel safe that you're going to actually get there. Sure, people can run the lights and cause accidents, and they do happen. But you aren't afraid for your life when you're going home. And as a matter of fact, you'll probably go for a drive in the next week with your family in the car because you can trust the system. People know the rules, and they work within them, and it works almost every single time. Okay? But there are going to be times when we need to know those rules, but we'll also have to look at what the exceptions are going to be. So I'm going to pick on Dawn once more, because Dawn and I, in 3 or 4 weeks' time, are going to be really, really good friends. And I'm going to be driving around in Toronto, and I'm going to look over at Dawn, and he had this condition before, and I'm looking over at him, and he's looking sweaty and clammy, and he says, "Marshall, I'm not feeling very good. I have this real heavy chest pain, and I know you're driving, and you're in a school zone, but there's a hospital that's only about 7 kilometers up the road. Can you get me there as quickly as possible? Because I want to go to the emergency department and get checked out." And I'm going to have to turn to Dawn and say, "Dawn, speed limit's 30 kilometers an hour. You're going to have to die." Actually, I'm not going to do that. As a matter of fact, if I sped to get there, I would drive safely, but I would speed to get Dawn to the appropriate type of care for the best health outcomes. And if I was stopped by the police getting there, or stopped by the college or somebody else like that getting there and explain what the situation was, they're actually going to turn their siren on and their lights on and get me there more quickly and safely. So know the rules, practice within them, but keep your patient's health outcomes primary and front of mind when you're moving forward. Begin with the end in mind, follow the processes, document your rationale, and notify appropriately. How many people have done this? I was a Cub leader, and I went through Cub leader training and Scout leader training. So anybody else do this? I spent a whole weekend with other leaders, so it wasn't Cubs down there, and I had to stand on the edge of this picnic table, and I had to let myself fall, and the people actually did catch me. And that felt really good for me, but it took a lot of courage to be able to let go. It also felt really good for the people who are doing the catching. We need to be able to trust in each other and trust in ourselves, that not only that we can make the leap, but actually the system is going to be there to be able to support us if we do make that leap. So on that, I'd love to enter in a discussion about this. It's really not a question and answer period because I don't have all the answers. But what I tried to do is paint you an idea of some of the pressures that society has and why we have this unique opportunity right now that wasn't there when I graduated. It wasn't there 20 years ago, wasn't there 10 years ago, but because of the demographics of the population and the concerns with the healthcare system, we can play a pivotal role in healthcare going forward. But it's up to us to be able to make that step and sort of trust that we can go off that picnic table and still be caught